Hi, this is Dr. Ban with Doc Talk. One of the most important questions that I hear all the time is blood pressure, right? We always talk about blood pressure as being the silent killer. And so with COVID-19, there's always a question about blood pressure issue. And my patient always are concerned about their blood pressure. Most of them are on at least one, especially if they have diabetes, obese, etc. So that's a really big population that have that, and so they want to know how do they regulate their blood pressure since they're too sick to eat, to get out, so their blood pressure naturally drops. So I bring on the expert, right? So this is Dr. Subh Agarwal, my friend, but our cardiologist and expert in the field. Remember, Dr. Agarwal is a board internal medicine, and then when crazy, Dr. Agarwal goes back and does in her ER and work for in the emergency department where we met. And so he did his residency in emergency medicine, so he double there. And then he comes back and he does a master and then does cardiology as a fellowship and physiology as well. So I invited somebody who's so knowledgeable in the field to explain hypertension to us. And thanks you. You're the man. Got to go to the expert to help us explain. So what is hypertension? Anything else I left out in your long list of expertise? I almost sound like I'm introducing Dr. Shiva, who has all these degrees. So now I got Dr. Agarwal here, who has all these board certification. Is unbelievable. But yeah, tell us about what is hypertension. Why should we all be afraid of hypertension? What does that mean?
Right. Well, thank you, Dr. Truong, for this beautiful presentation and for inviting me again to your now world famous podcast. You have been very active and you have taken on COVID-19 to educate your patients and take care of them. And I think there have been some concerns with COVID-19 and high blood pressure. So I just wanted to talk about hypertension first, and then we can talk about the issues with COVID-19. So as you know, hypertension or high blood pressure, it's basically physics. So it's the column of fluid which is exerting pressure onto a wall, and here it happens to be blood, which is exerting pressure on the vascular endothelium. And when we measure that force, the perpendicular force, when it's measured, it's called blood pressure. And basically, it's an interplay of various factors. But in general terms, it is the cardiac output, the interplay of cardiac output, so the blood which is ejected from the heart, and the relationship it has with the resistance to the flow of that blood, which is we call peripheral vascular resistance. So the interplay of these two forces in general is what is blood pressure. So now, over the years, through Framingham heart studies and actuarial analysis, and now the nurses' health study, the physician heart study, and many observational cohorts, we have come to realize, as you mentioned, that high blood pressure is a silent killer, in terms that it can lead to kidney disease, it can lead to stroke, heart disease, death. So all these adverse outcomes can happen from high blood pressure. And there is a problem of awareness. We may not be even aware that we have high blood pressure because it does not really cause any symptoms initially till you have target organ damage. So kidneys have already gotten hurt, or the heart has enlarged or thickened, and you go to the doctor's office, they get an EKG, or they get your blood pressure, and now you make the connection. So there's a lack of awareness. And since it does not cause symptoms right away, there's no pain in the body, so you're not seeking help. And you may not take your medication. So I think over the years, we have realized this issue. And it shares relationship with other risk factors, like diabetes and cholesterol or smoking, physical inactivity, obesity. So there's interplay between the various blood pressure and other risk factors.
So it seemed like to me, it seemed like the one thing you have to understand is the heart's job is to be able to push the blood throughout the body, right? It's a pump that pushes the blood throughout the body to the brain, to your lungs, all the way through to be able to get the exchange of oxygen. So you feed every living cell throughout your body and then be able to spread all the nutrients. So the blood pressure itself is important because without it, we can't get the flow of the nutrients and the oxygen to circulate to all the different organs that we need. So that part is important. But what you're saying is that what happened when over time, over a period of time, there's injury that occurred or these inflammation that damaged certain area of the body, and it causes the heart to have to work harder to be able to circulate to get the same work that's done. And so the damage from that overexertion leads to what? Like what happened to the heart when you're working so hard because now you're not that same young person that originally you have this pump that naturally pumps and it work beautifully. Over time, you got a lot of injury to the artery. You have damages. You have other diseases that come with it that cause so much more problem. It leads to your heart saying, I got to work harder because maybe there's stiffness complying in the blood vessel. And so what's the end point? Why are you as a cardiologist care so much about this? What will be the harm?
So, I mean, many studies, as I was mentioning, so I will just mention one. There was a meta-analysis of 61 studies. So it's a really good data, 61 studies put together. And they found that the risk to the cardiovascular organs, when we talk about heart or kidney or the brain or the vascular tree, it's cardiovascular. So all the other organs of the body, the risk from blood pressure, as we know it, is continuous. So in a log linear fashion. So meaning that for every jump of blood pressure by 20 points, either systolic. So as you know, blood pressure is recorded with two numbers, which pops out. The systolic pressure when the heart is contracting and the diastolic pressure when the heart is relaxing. So those are the two numbers which we are familiar with and our patients are familiar with. So when there's a rise of blood pressure by 20 points, the upper number, the numerator, systolic, or there is a rise of the denominator, the diastolic pressure by 10 points, it increases the risk for dying or heart disease or stroke by 2 times. So there's a doubling of risk every time the blood pressure jumps by 20 points over a range. So from a range of 115 millimeter mercury to 180 millimeter mercury, that's systolic, or from 75 to 105 millimeter mercury diastolic. If the blood pressure fluctuates and goes higher, we are seeing adverse effect. So in terms of the heart, let's say the heart muscle can become thick. As you can imagine, the heart has to work harder to pump blood, so it can become thicker. Over time, the heart will fail, and we call that dilation of the heart. So cardiomyopathy sets in. The heart might fail, so you get heart failure. The most common type of heart failure, which is associated with hypertension, is the one where the heart muscle is preserved, heart function is preserved, but it becomes thicker and non-compliant and doesn't relax as well. So 50% of heart failures are preserved heart failures. And then the rest is the reduced ejection heart failure. Now you can imagine that if blood pressure to the brain goes up, we are at risk for strokes, in particular hemorrhagic strokes, so bleed in the brain. Higher blood pressure can cause damage to our kidneys, which is the filtration part of the system. So these are the eye damage, retinopathy. You will see, you go to the eye doctor and they look at your fundus. And so you'll start seeing those changes with rising blood pressure. So that is the concern.
So can you show us how to categorize the blood pressure?
Absolutely. So you know that since the 1950s, the Joint National Committee has been coming up with guidelines. And it came up with the JNC 7 in 2003. And now we have the JNC 8, which came out, but that was really, people were not in favor of the JNC 8. So now we have the 2017 guidelines, which came out. And I actually made a slide so I can share with folks. Let's see if I can pull it up here.
Yeah, if you can share, and it'll be easier to see what are the classification, and so people understand where they are.
Okay, let's see if we can share this slide. Do you see it on your side?
Yes.
Okay, so this is the 2017 guidelines for high blood pressure, which were published. And a lot of data went into this publication. In particular, they looked at the Accord trial, which were looking at intensive blood pressure monitoring in patients with diabetes. Then there was the SPS-3 trial, and then the Sprint, which was very, very well-known trial. And they found that the cutoff for blood pressure used to be 140/90. If someone had a blood pressure higher than that, we used to call them as having hypertension, requiring therapy. So those cutoffs have been changed. So now if someone's blood pressure is less than 120/80, they are called normal. Between 120 to 129, elevated. But now if you look at hypertension, the cutoff has gone down to 130. And anything over 80, so 130/80 millimeter mercury is the number to remember. So the cutoffs have been changed, if you can understand.
So when it say elevated, so for me as a practitioner, what does that mean for my patient? What should I be telling them?
Well, so again, they came with many caveats, these studies and guidelines. So they also said that, okay, if you have already clinical cardiovascular disease, so someone who has heart disease, they've had a heart attack, someone has diabetes, someone has kidney disease, and there are criteria to define kidney disease. They look at GFR less than 60 as having stage 3 kidney disease, or retinopathy or other special disease like stroke. So if you have clinical cardiovascular disease or these conditions I mentioned, and the blood pressure in addition to these conditions is greater than 130/80, then besides non-pharmacological interventions, which we will discuss, we need to think about medical therapy to reduce the burden of heart disease and death. Second, if you do not have these conditions, but your risk for developing these conditions is greater than 10% over the next 10 years, and your blood pressure is more than 130/80, then they should be on medical therapy besides non-pharmacological. So those are the two things. And the third is, you may not have these conditions. You may not have diabetes. You may not have heart disease. You may not have that risk of developing heart disease over the next 10 years. But you have stage 2 hypertension, which they defined as more than 140/90. Then these patients should be on medical therapy with medications. So that was the gist of the guideline.
I like that. So what we're saying is that, look, you have to think about the big picture. What are all the other issues that's involved with your patient, right? So don't just look at a number and say, well, whether or not I need to put you on the medication. And that I hear that very common among residents that are training to be full-time physician, and all the way to a physician, is that we look at number, and a lot of time we have reps that come to us and talk about different medication, and then we see the patient maybe once a week, once a month, and then we start them on medication. What you're saying is, hey, look at the totality of your patient. What are the different risk factors? What are the different comorbidities or different type of medical issues? Do they have diabetes? Do they have kidney disease? Do they have some kind of hyperlipidemia, like some kind of cholesterol, triglyceride issue? Look at all of those at a total and see how your patient fit in this. If you have more of these categories, then you have to worry about them. Okay, how did they modify their lifestyle to bring it back down? But even if you didn't find any of those things, and if they're in stage 2, then you really need to consider to put them on a blood pressure medication to help decrease the risk. Because from what you're saying, if you have a 20, I guess, mercury of millimeter mercury increase, you have a twice the risk of having some kind of injury to your patient. So that's for what we want to get people to understand a little bit. It's not just a number. It's really looking at the overall totality of what's going on with your patient. So now maybe you can lead us to what are the different classes of medication, because that can be confusing because we have patients on so many variation of medication. Why are we on so many different ones? What are they, and why do we put them on these medication?
Yeah, absolutely. And Ban, before we get there, I also wanted to just make a small note that also we jump too quickly to label someone as having high blood pressure. So I think I would urge caution to those who are watching us and to the physicians that we cannot just rely on a single blood pressure reading. So that has to be done over multiple visits. So at least 2 or more. And there has to be at least 2 or more readings on a single visit. So let's say a patient comes to us today, then in a month you want to bring that patient back, or in a few weeks, and you have to have multiple readings in each sitting. And you average that out to come to a conclusion that they may have hypertension. And have you tried your non-pharmacological interventions, which we will discuss later, to see if the pressure goes down?
Oh, that's a very good question. Then, if we need to have multiple reading, not just one reading, which makes sense because the blood system, as we can see, is very dynamic. It's changing. Are there any point to having them test it at home for you, to bring it for you, documentation? How would you advise them to do that?
Correct. So as you know, I mean, initially all this data, which I have been mentioning, these meta-analyses and these trials, they have been done in an office setting. The blood pressures have been obtained in an office setting. So most of the data which we are putting out in public for public guidance and for clinicians to do therapy is based on office data. But now there are studies which are looking at home blood pressure monitoring. So that's one. And the second is ambulatory blood pressure monitoring. So those numbers they are lower. The cutoffs are slightly lower compared to the ones which is out there in the public. Because the blood pressure, as you mentioned, is affected by a number of factors. Your autonomic tone is different at home compared to work. You're relaxed. There is something called dippers. Your blood pressure dips down in the nighttime. So there are different numbers which comes out from home monitoring and from ambulatory monitoring. You may be able to unmask hypertension. So that's one, that's called masked hypertension. The second is, which is very familiar now with the patients too, which is called white coat hypertension. They come in the office, their blood pressure is high, They see that white coat. Just this notion of getting your hands crushed by a cuff is enough to release adrenaline and raise your blood pressure. So all those considerations are there. So I think there is now, increasing awareness that ambulatory blood pressure monitoring is actually in some way superior to the office monitoring in outcomes. So there is some data out there. Also, the technique of taking a blood pressure is very crucial. So in these trial data, when I mentioned Sprint and Accord, patients come in our office, they relax for 5-10 minutes. There has to be, you don't talk to your patient. They're not lying down or sitting on the examination table, but they're sitting on a chair with their feet on the ground. And the cuff is the right size. It is at the level of the heart. You make sure that they've used the restrooms, they've not smoked for the last 30 minutes or had any coffee in the last 30 minutes. So many variables are, those confounders are taken care of. And that will give us the accurate blood pressure. Because I think it's a big deal. Putting someone for lifelong therapy should not be taken lightly, as you and me, no. We try to take this very seriously before we start them on medications. And then the question is that what device to use to measure your pressure. So in the office, we used to use the initial devices we used were auscultatory devices, looking and listening for the Korotkoff sounds with the rise and fall of the blood column. So with those mercury, sphygmomanometers, the machines are out of fashion now, but they were a direct measure of the blood pressure. Now we use oscillometric devices, which are automated, and they are an indirect measure of our blood pressure. They don't measure blood pressure directly. So there is some noise in that data. I think there is some noise because they use algorithms based on population level data and come up with an indirect measure of our blood pressure. Because we can't have patients learn how to take blood pressure at home using mercury, sphygmomanometers, we have moved to the oscillometric method. So again, but that's the whole idea, that these machines needs to be calibrated. They need to bring these machines to the physician's office and make sure that this machine is giving the same information which they are getting in the physician's office. So calibration is essential because otherwise they will give us wrong numbers. So once we have done that due diligence, then we can move if they are still high and they meet those criteria, as I showed from the 2017 guidelines, then we can move to drug therapy.
And then you have to, and like you said, it's very important is that once you start people on the medication, I find that a lot of time nobody make any changes, right? Because how often do they see you as a cardiologist versus like somebody like me or somebody in a primary care setting? And then they're labeled a certain way, and we do a good job of adding more medication. We never subtract medication. So that's a very good point to make. Is there a value in different areas of the body? Because that's the other question that comes off, where they put their cuff among the patient.
So, technically, you should look at both arms, and you should take the blood pressure which is higher in that arm. So let's say your blood pressure is higher in the right, that is the one which should be mentioned, not the one on the left, which is slightly lower. You can also measure thigh pressure and calf pressure. And then you have to pay attention to the the cuff size. So at least 80% of your arm should be encircled by the cuff. So if you have someone who's larger and you put a smaller cuff, erroneously the blood pressure will come high, and vice versa. So if someone puts a large cuff in a smaller individual, the blood pressure would be lower. So I think these are important things. It's harder, I understand, in a busy clinical practice. And that's why I think it's important for patients to know these things. So they seek the right physician who will take the time to do these things. And, because this is very important. You are making decisions about putting someone on a medication which has its own potential to cause harm, and then adding on therapy on top of that. So I think you're correct. Once the patients go on medications, hardly do I see they come off it.
Mm-hmm. So when we talk about the different category of medicine, if you don't mind, different classes of blood pressure medication.
Right. So, there's a plethora of medications out there now. We have the thiazide-like diuretics.
Mm-hmm. So diuretics.
Correct. And then there's the loop diuretics, which are much more intense. You have the potassium-sparing diuretics. So that's the diuretic class. And diuretic means that they help in loss of water. They excrete water and salt and lower the blood pressure. Because as you know, there are various mechanisms of blood pressure. The second is beta blockers. So they slow the heart rate down. So the cardiac output goes down. As we mentioned, one of the mechanism, forces of blood pressure.
Yeah.
They also lower the vascular tone. So the vascular resistance over time goes down. So that's their mechanism of lowering blood pressure, lowering the heart rates. That's the mechanism for blood pressure, for beta blockers.
Mm-hmm.
Then you have calcium channel blockers, which is one other major category. Similar action, but there are various kinds. They're subdivided into some vasodilators and non-vasodilators. Then the major category is the angiotensin receptor blockers, which you mentioned, and the ACE inhibitors, which is the angiotensin converting enzyme inhibitors. So these are some major categories. There are some others. Like in cardiology, we use vasodilators a lot. So we use hydralazine and nitrates in combination for treating heart failure and blood pressure. And then something which I really don't like, but I see it used a lot, and I'm trying to see how we can get our patients to get off that, is clonidine, which is a alpha-2, it's a sympatholytic agent.
Yeah, it's an agonist.
So it causes bradycardia and lowers blood pressure, but the side effect is rebound hypertension because short acting. So you have to give multiple doses, and adherence to these medications goes down when there are multiple doses. So in broad terms, these are the major categories, and they all have their pros and cons.
So the beta blocker, our example, are metoprolol, tenolol. What are some of the newer ones too that we see? Bistolic or some of the.
So I normally, when I talk of beta blockers, I've been using a lot of Lopressor, which is metoprolol, and then I use a lot of atenolol, because it does not cross the blood-brain barrier. So it's a great medication to use in an older population.
Yes.
Because if you use a medication like metoprolol, which crosses the blood-brain barrier, it can lead to nightmares. So atenolol will prevent that nightmare from happening. So it's a good medication for that population. Now, if someone has heart failure, then you want to use something called an alpha and a beta blocker combination, which is, there are two drugs. One is carvedilol, and the other is labetalol. So normally the studies have shown that carvedilol is the drug to choose in the systolic forms of heart failure. So heart failure, reduced ejection fraction, that's the drug of choice.
I learned something today. I didn't know why the cardiologist was using that so much. Oh, that's a great point for me. So I learned something fantastic. I love that. How about your calcium channel blocker? Gives us some examples so people know, because some of the people will know that they're on these medication.
Right. So the calcium channel blockers, as I said, are subdivided into two categories. One is very commonly used for blood pressure management. It is the dihydropyrimidine. And this is, normally I use something called amlodipine, which is Norvasc. And the dosage is around 2.5 milligrams to 10 milligrams. So this leads to vasodilation of the blood vessel. It has minimal effect on the heart rate as such and the contractility of the heart. And then the other calcium channel blocker is the non-DHP, as we say. And there are two categories. Like in AFib, atrial fibrillation, you have seen the use of verapamil and diltiazem. Or for any supraventricular tachycardia, so any fast heart rates, like AVNRT, ORT, besides ablation, these are the drugs which can be used. So those are the common drugs to use in terms of calcium channel blockers.
How about your ACE inhibitor that people tend to use and you see more in a diabetic patient?
Correct. Yes, absolutely. So when we talk about ACE inhibitors, the drugs which used to be used in the past, still used somewhat, is captopril. So it is a shorter acting ACE inhibitor. So it's given BID or TID. But now it has given way for longer acting agents. So you can use enalapril or lisinopril. And then there are some studies like HOPE trial, which used a drug called ramipril. So that is your ACE inhibitor. And the other variety is the angiotensin receptor blocker, which is something like losartan, Cozar, that's the trade name. And then valsartan, I think the trade name is Diovan. Olmesartan, telmisartan, these are the angiotensin receptor blockers.
Yeah, so some of these that the patient will probably remember more if the ACE inhibitor tend to cause these sort of dry coughs, very annoying to them. And so a lot of times some of their physician will change into the ARB, which you were talking about. Yeah. And so these are things that work at the kidney level.
So, I mean, the mechanism of action is through the RAS system. And I think I should put up a slide because that will help us understand that better. So let's see if I can share that screen with you. Okay, there you go. So this is what I was trying to show, that this is one major mechanism, the way how ACE inhibitors and angiotensin receptor blockers work. So when there is either loss of blood volume, meaning blood pressure is low, the nutrients to the kidneys go down, because kidney plays an important role in blood pressure mechanism. So the kidney cells, the JG cells, release a hormone called renin, and that converts angiotensinogen into a decapeptide, angiotensin 1, which travels to the lungs. And in the lung, the ACE enzyme converts the angiotensin 1 to angiotensin 2. And this angiotensin 2 acts on the angiotensin 1 receptor to release aldosterone. This is the classical RAS pathway, which leads to increased blood pressure, pulmonary, as well as systemic vasoconstriction, increased sympathetic tone, and can also have some adverse effects such as fibrosis, oxidative stress, inflammation, cardiac hypertrophy. So as you know, nature does not allow just one thing. It also has a counter-regulatory axis, and that's where this comes in play. The angiotensin 2 is broken down by the ACE2 into angiogenesis 1-7, which goes and forms the MAS receptor proto-oncogene receptors, which has the opposite effect of causing vasodilation, anti-inflammatory, vasodilation, prevents hypertrophy and fibrosis. So I think that's why I put up this slide, because I think this would make it clearer.
Can you put that would be a good one because it leads us to our next question. And the question was the study that came out of France with Dr. Didier Rao. And he talks about this angiotensin receptor that you're looking at and how its interaction, that he felt that people on these ARBs has a angiotensin 2 receptor has a worse outcome. Can you make that link for us? Because I love that slide you have there because it actually helps us to understand that.
Yeah, so I think that's why I put up this slide, because I think it will lead us nicely into that important question. So what they have seen is that, when they looked at these patients who were dying from COVID-19 or they were sick from COVID-19, they found that they all had significant comorbidities, and 30% of the population had hypertension. And as you know, increasingly, because it's a class 1 recommendation to use ACE inhibitors and angiotensin receptor blockers, increasingly you will see patients are on ACE inhibitors. And we are using it to prevent damage to the kidney if they have diabetes. If they have chronic kidney disease, we are using it. Certainly, we are using it in patients who have heart failure, the systolic kind. So our main drug now has become ACE inhibitors and angiotensin receptor blockers. So that's where this theory came from, that is it that ACE inhibitors and angiotensin receptor blockers are causing damage to these patients? And the reason is that, as you know, the SARS coronavirus 2 attaches to the ACE2 receptors to gain entry into the lungs. By the way, the ACE2 receptors are also present in the intestine, epithelium. It's present in the heart. It's present in the lungs, as you know, in the kidneys. So it's present, it's ubiquitous. I feel like it's there all over the system. But it has a tendency to attach to the receptors in the lungs. That's where it's gaining entry from. Also, the ACE2 is present in the plasma. It's in the blood as well. So there was a concern that by blocking the ACE1 and 8 angiotensin receptor blockers, we are causing an upregulation of the ACE2 receptor. As you know, when we use beta blockers, there's upregulation of the beta receptors. So when we block this pathway, the RAS pathway, we are increasing the amount of ACE2. And that's where I think Dr. Didier's concern was, that could it be that we are causing more harm by using these medications? So there is some evidence. There is theoretical evidence that could it be a possibility? But there is a preponderance of evidence. There's a higher wealth of evidence that actually it could be benefiting the patients and preventing that lung injury, which we are talking about. So by increasing ACE2, we are actually increasing the angiotensin 1-7, which is anti-inflammatory, which is preventing the oxidation and the fibrosis, causing, preventing the hypertrophy, preventing the vasoconstriction, which is happening in the lungs, preventing the serious lung injury and the, diabetes and hypertension and cardiac disease, which we are seeing in that patient population. So that's one. Second, if you look at the epidemiologic data, COVID-19 was seen primarily affecting elderly people, so 60 plus, and you are seeing this affecting men more than women. But the ACE2 receptor is higher in women and in younger people. So if you use that argument that, well, we will upregulate ACE2, we should have seen more death in women and in younger people. And you don't see that. You see the opposite. So that's the second point. And the third point is that they have done studies even before this pandemic came. We have had patients who have ARDS. So our scientists and physicians are constantly looking to improve patient outcomes. So we have done the studies with ACE2, and by giving recombinant human ACE2, we saw better outcomes. So there are some studies looking at actually giving angiotensin receptor blockers like losartan to improve outcomes in patients who have ARDS. So again, these data are not proven. Mm-hmm. So we are not sure what will happen, but these are some, points to ponder, that perhaps we may not be causing harm. We might be actually causing benefit by giving these drugs. And if we increase the amount of soluble ACE2 in the blood, it can bind to the, virus and decrease the viral load, which is attaching to the, the lung epithelial ACE2. So there is some theory regarding that too.
So that's a very good point to see. Just because you see that there's an association with this medication that he noticed in over 1,000 patients that he noticed some more death, it doesn't mean that's what's causing it. And what you're saying is a very good point, is if you're looking at people that have more of these ACE receptor in women and in children, and ideally that they would be the worst off. But in this case, you don't see that. And by blocking with these medication doesn't necessarily mean that you're causing harm. So it's something to think about, but it doesn't necessarily mean that you jumped at something, because an association is not a causation, right? And that's what you're seeing. So that's a great point to ponder, because I hear that question more and more, and I want to make sure that we understand that it's something that is not very well understood, and that two sides to that argument.
Correct. And I think that's why, because there was so much concern regarding this, even I was concerned, initially when this data was coming out, then, every physician was concerned, because we don't want to cause harm. We want them to have good outcomes.
Yeah.
Iatrogenically, there is no intention on either your or mine or any other physician out there to cause harm.
Yeah.
So I think that the European Society of Cardiology and the American College of Cardiology had to come up with statements and clarifications that, the data is not clean. We don't know yet. We would, and abruptly stopping these medications may actually cause more harm. So again, through your podcast, I would like to urge folks who are listening that it seems like there is a wealth of evidence suggesting that perhaps there is benefit by using these agents. Certainly, there is benefit when you use it for high blood pressure in patients with diabetes, high blood, kidney disease, or heart failure. But also, there might be benefit in COVID-19 patients. But again, take that with a grain of salt. We do not have conclusive evidence, so further studies, are being done at this time. We don't have the complete data. I would not stop this medication.
So how about this? So let's say your patients have been sick for a few weeks now, and they've been very weak, really haven't been out of bed, haven't really eaten much, and everything is sort of gone down, and they notice that their blood pressure start dropping. I've seen patients in the low 100 and getting in the 90s. How do we go about managing? How do we back off the medication? And let's say if they're on, it's simpler if they're on one, but if they're on a few, a combination of beta blocker, and they're on some kind of angiotensin receptor blocker or an ACE inhibitor type of blocker, how do you sort of back it off for them? Think about helping the primary care doctor backing off a little bit.
Right. As you mentioned, no blood pressure, we can't function.
Yeah.
We started with that. So, I think at that time you have to withdraw this medication. Either you reduce the dose of this medication or you completely take them off this medication, because you do want a systolic pressure of greater than 90 to 100. That's my cutoff. Even when we are, writing prescriptions, when I'm treating advanced heart failure patients, my goal is to get their blood pressure systolic to 90 to 100. But if you are someone who is, don't have heart problems, you just have high blood pressure, you don't want their blood pressure to be that low. At that time, you will have to withdraw or reduce the dose of the medication. So let's say they're on 50 of losartan. That's not a very high dose. You can go down to 25 or totally off altogether till the blood pressure improves. The beta blockers, if they're on high doses, then you are a little bit more cautious. You don't want that surge, adrenergic surge. So you may taper it down slower. But again, if the blood pressure is 90 or the heart rate is 50, there's no option but to take them off these medications, because they may be dehydrated, their kidneys may not be functioning as well. So they may have a high serum level of these medications. So I think you can safely, in this situation, taper or withdraw these drugs altogether.
Yeah, and I think that's the one thing that's important for a lot of physicians to see, because once you get a lot of patients that are older and they're sicker and not being able to take care of themselves, you got to be very careful. What we talked about before, diabetes medication, but in this case, is blood pressure medication. It's going to lower their heart rate, right? It's going to lower the blood pressure. And so on the beta blocker, you're working at area that's going to be very hard. It's getting up is hard for them. Getting up, they can pass out. So having syncope is something that will happen, but not having, remember from beginning, from what you're saying is that you need the heart to be pumping to get the blood circulating, getting the nutrient, the oxygen to out of the body. But if you're giving something that artificially drops it and they themselves are not being able to eat, drink, and all these things naturally will bring down the blood pressure, we have a really big problem here. And so that's the one thing that we want to be careful and that we want to manage patients. So there's two thoughts here. A lot of time people think that you don't need to treat the patient with COVID with medication and that they can naturally let their immune system function. Okay, so that's one thought. The other thought, maybe we need to treat them with medication. But in either case, the patient are going to be pretty sick. You're going to have to manage their medication to make sure that you can have good outcome for the patient. And that's why this talk with you is so important, because it shows the different variation that we should be looking at. And look how complicated it is. We put people on medication, and when you go through this, it really shows how well we're taking care of our patient. Do you really know what they're on? You know the list of medication they're on. And sometimes it worries me so much that older patients are on, 6, 7 medication. It's a full-time job to figure out what medication to take, so that's very scary. And knowing that if they get sick, how are you going to manage these medication for them? So yeah, thank you very much for the education today. Any final thoughts for us and for our practitioner or patient to be concerned with?
I mean, one other thing I wanted to add, that normally when I start someone on hypertension medications, I normally go with 2 medications. So although we are trying to reduce the number of medications, it's better to be on 2 or 3 so that you're not maximized on one, because that way you're minimizing the toxicity of the drug. So that's one thought. And second thought is that I think we need to understand that hypertension is a complex disorder, and there are ways to treat that through natural ways as well. Mm-hmm. So we should not forget that there are non-pharmacological ways to reduce blood pressure. So we need to understand that a little bit better. So it's a polygenic disorder, meaning there are multiple genes involved in the mechanism of blood pressure, not just one. So there are some syndromes, like Little syndrome, Gordon syndrome, whatnot, which are single gene disorders which can cause hypertension. But mostly it is a polygenic disorder. And most of the time, unfortunately, we have no idea what caused the blood pressure. So 90% of them are essential. Only 10% of the time, we know that there's a secondary cause to that blood pressure. So let's say they have thyroid disorder, hypo or hyperthyroidism, that can cause hypertension. Or they have renal artery stenosis, or some other disorder like pheochromocytoma. These are some zebras which we should look for before we start them on blood pressure medication. So I think we should look for those. And then we should also make sure that, like, look at obesity, for example. Obesity, they found out that 40% of individuals who are obese, they have hypertension. So if you reverse obesity, you could reverse hypertension. They may not have to be on long-term medications, which will prove toxic. You look at their physical activity, their alcohol intake, their salt intake. There are some people who are salt sensitive. So there is, this demographics, genetics, ethnic folks. So a large amount, numbers, I should say, of African Americans are salt sensitive. So the same salt intake can lead to a disproportionate rise of blood pressure. So those are the salt sensitive individuals. Low intake of potassium, or less fiber in the diet, or less plant proteins. All those things, I think, are food for thought, which I think we should look at. Exercise, how much exercise they're doing. There's enough data to show that if you lose 2 pounds, you lose 1 millimeter mercury. You exercise, you can drop your pressure by 5 to 8 points. You eat good food, which is rich in leafy green vegetables, lean, and proteins. You can drop your pressure by 11 points. So if you look at the epidemic data and this data, some of the pressure change you see is similar to the drugs you take. When you look at all these trials out there, they dropped the pressure by 5 millimeter mercury, and it is statistically significant, and it's out in the market. So, I don't know I think through your podcast, I want to make sure that folks are aware of these, things which are out there. Stress reduction, increasing calcium and magnesium in a diet, doing guided breathing exercises, yoga, meditation, all those things are the non-pharmacological interventions which we can provide to our patient, you and me. And I think through your podcast, I want folks to understand that, there are people out there, but patients need to seek the right person who can actually guide them through this process. You can go to a major healthcare center and you're seeing them every 10 minutes. How much time are they actually spending with you? At the beginning of the talk, I said it takes 10 minutes to actually take a good blood pressure. And you're given 10 minutes to spend time with your physician.
Yeah.
So you can imagine the care you are getting. no one is taking the time to sit down with you to talk about your diet or how much exercise you're doing. So I think I want to make sure that folks understand that they need to seek out the right people who can spend time with them and can actually guide them in that process so that they can reduce your blood pressure the right way so that you don't even have to start the blood pressure medication. So I think that's the message I wanted to give.
Well, I think that's a great point because it leads you to what you do. So tell us, like, what is it that you do outside of your academia and your role as a cardiologist? You put on a very great podcast and also a program. And tell us about the program because you actually one of the few cardiologists that does this naturally, and you do this on a regular basis.
Correct. Well, thank you for that. I mean, I am actually interacting with like-minded individuals. It's like you and me are talking about this. So increasing our knowledge base, number one. Number two, interaction with like-minded individuals, forming a network. Number three, having our own, channels, educational channels, YouTube channels, websites, and, spending a little bit more time than even what is allotted to me. So although I am always in friction with the administration, I am trying to spend a little bit more time with my patients, gently tell them that, hey, listen, there is a YouTube channel I have. You could go there. You can get more information. You could email me. And again, at no charge, you could email me. You can watch my videos. If you have any questions, that's the only thing I can do. You know that. I know that. Ultimately, it depends on that person who wants to change. But basically, what I'm trying to do is provide them with the resources that they can use at their own time and being available to them. If you have any questions, I have helped a lot of folks get off medications. So I think it's doable. In some, we can't. There is a genetic component, as I mentioned. But in a large majority of patients, we can. So that's the mantra.
Yeah. So tell us what's your YouTube channel so that people can follow you.
Right. So it's called holisticworkshop.org. You could go on YouTube, type holistic workshop, and you will get to that flower symbol. Click on it, subscribe, share with your friends. You can go to holisticworkshop.org, which is my website. If you want to learn about interesting recipes and also learn a little bit about the science behind those recipes, you can visit my YouTube channel. We have a video on guided breathing. I have actually put a video, me and Dr. Ban talking. So we live in exciting times every day. I think every day I'm grateful for what we have. And I think everyone should be hopeful and grateful. We will prevail together, and the future is only going to be better.
Yep.
Despite this gloom, which everyone is predicting, I think we will do very well, and we are going to become winners, and the future is only brighter and better.
Okay. Thank you, my friend. Thank you for all the great information as always. And then make sure you learn a lot more from Dr. Subh Agarwal with his holistic workshop. I learned quite a bit from there. And, it's one of those people that out there, great heart and great knowledge. And we got to follow the right people. So thank you, my friend. Thank you for all the wisdom today. Okay. And then we will talk again.
Thank you so much.
Okay.